Alzheimer's is a different type of dementia. It's very different from Parkinson's dementia and Lewy body dementia because there's a lot more actual memory problems, inability to remember new memories, or they're forgetting conversations that they had 10 minutes ago. They're repeating questions over and over again. And there's a lot of struggles between the executive function in such patients. Alzheimer's also generally has this steady, predictable decline, whereas Lewy body dementia has this good days, bad days. There's fluctuations. 1 hour someone's good and lucid, and another hour they're maybe confused or drowsy. Today's episode is one I've been wanting to do for a long time because I hear about it every day in some fashion. A patient who's starting to forget things, a caregiver who's worried about hallucinations, or a family member seeing personality changes that they just can't explain. Parkinson's disease is not just about movement, it also affects the mind and personality. In this episode, we're going to explore the differences between Parkinson's related dementia and other types of dementia, why psychosis sometimes develops, and most importantly, what can be done to support the people living through it and the loved ones.
Dr. Thakkar, you've said that one of the most common questions you get is about Parkinson's and dementia. Let's start there.
Yeah, so there is a lot to talk about today, a lot to cover. We may have to do another episode about this, but the unique situation is there's always a question about Parkinson's disease, Parkinson's dementia, Lewy body dementia, Alzheimer's dementia, and other forms of what we call vascular dementia. So we're going to distinguish between them. Sometimes it looks very similar, but the key thing is the challenges and how they separate. And there's going to be some overlap too. So let's start with one thing is the most important is it's really about timing. With Parkinson's, we do see a lot of movement issues, tremors, stiffness, slowness, but the timing with Parkinson's dementia is when someone's developing memory issues, they must have some degree of motor control issues well before, and then the memory, the processing, the executive issues typically happen later. There are, again, something that's very easily confused and clinically something called Lewy body dementia, and it sometimes is overdiagnosed by the dementia specialist or the neurologist, and it kind of is used as an umbrella term that includes maybe Parkinson's dementia and Lewy body dementia. But Lewy body dementia is caused by the same protein that causes Parkinson's disease, and that's the alpha-synuclein. It just spreads differently through the brain in different areas, and it does affect more of the pathways that are for mood and processing. So Parkinson's disease, again, is the timing part. There's shaking, there's motor control, balance issues that happens well before the cognitive implementation of like slowness in processing and memory. And dementia with Lewy body usually has a cognitive decline. It has personality changes, maybe more anxiety, maybe more agitation well before, and then maybe 1 or 2 years into the disease, you may start seeing someone that's slower in walking, slower in motor control, maybe some tremor. But the key difference is personality and memory issues before or sensitivity to our Parkinson's medicine. So that means when we give levodopa or some of our Parkinson's dopamine agonists, those medicines may aggravate someone with Lewy body dementia. They make them more confused or having problems. Now, Alzheimer's is a different type of dementia. It's very different from Parkinson's dementia and Lewy body dementia because there's a lot more actual memory problems, inability to remember new memories, or they're forgetting conversations that they had 10 minutes ago. They're repeating questions over and over again. And there's a lot of struggles between the executive function in such patients. Now, Alzheimer's also generally has this steady, predictable decline, whereas Lewy body dementia has this good days, bad days. There's fluctuations. 1 hour someone's good and lucid, and another hour they're maybe confused or drowsy. And that's not common with regular Parkinson's dementia. Parkinson's dementia is typically patients function very well. They have their job for a long time, but maybe 10, 15 years into disease, there's changes go on. So there is those timing changes that happen. And that's how we utilize the differentiating factors.
And a person with Parkinson's will always develop Parkinson's dementia or not?
You know, that's a really good question. Does someone with Parkinson's develop dementia over time? I think there's cognitive impairment. I think there's slowness in processing. Do they actually develop the dementia, which is difficulty with multitasking, multiple thoughts, sequential? Yes, some degree. Do they develop hallucinations and delusions, which is part of more advanced dementia? They could. Sometimes it's sensitivity to medicines. Sometimes if they're exposed to some certain strong anesthesia, if there's certain medicines that cloud their thinking, we can also see that. If they get really bad infections, again, you think about a blood infection, it can cause hypotension. You get infection in the blood, it can cause urinary problems. But it does affect the brain. And so when there's an infection that's really toxic and it does affect the brain, someone can hallucinate or have delusions or just not think well. That doesn't mean it's a dementia, but maybe they're more prone to developing dementia as time goes on with Parkinson's.
Okay, so hallucinations and dementia, they're not the same thing, but they tend to correlate with these types of disease.
Yeah, so we may see patients who have Parkinson's dementia develop slowness in processing, right? That's early on in their memory problems. They develop in a dementia where it's like harder to again, juggle too many tasks. Like maybe they were doing their taxes and they have a tough time now doing their taxes. They have problems with, again, conversations that it's hard to get their words out. And so this is mild to moderate. And then as the disease progresses, the dementia becomes where there could be visual hallucinations, visual disturbances, seeing people pass by. They may have some psychosis there associated, but it's not harmful. It's not scary. But it's one of those things that progresses in their cognitive decline. So it's part of the progression of it. But someone who has dementia with Lewy bodies, which is again, similar disease, but not the same as Parkinson's dementia, they have a lot more hallucinations, agitation, confusion early on.
And Dr. Thakkar, you've mentioned Parkinson's disease dementia, Lewy body dementia. How are these related to Alzheimer's?
They're again similar but different. Alzheimer's again is another neurodegenerative process. It's another abnormal protein that's spreading. We call it tau proteins, and these tau proteins spread into areas of the memory center, the hippocampus. They affect the frontal lobe, whereas with Parkinson's, you don't get these areas typically affected by the tau protein, right? We see typically what's called alpha-synuclein. And Alzheimer patients don't come with tremor, stiffness, and slowness that you typically would expect with Parkinson's. Purely Alzheimer's is a memory problem. They have a forgetfulness of names. Patients have slow processing with, if someone told them hey, how do you get from this place to another place? Maybe the person can get easily confused. They mistake people they know very well, family members. And Parkinson's patients don't typically have that. Patients with Parkinson's, they know who's around them. They don't get agitated by those around them. There is this executive function, a brain fog that patients with Alzheimer's and Parkinson's get, but there are difficulties in someone with Alzheimer's. They have a problem with problem solving. They can't manage their checkbook. They can't plan meals. Certain things that are routine become harder to do in their day. And so, there's this zoning out that may happen for some of the patients with Alzheimer's. They sleep a lot during the day. And you may see that also with Parkinson's. Patients get tired easy. But, there's so much variability with the two disease states. And there's also, again, medications that could aggravate the daytime alertness and focus.
So at what stage in the disease do cognitive symptoms typically begin to show, and what are the first signs families should look out for?
So cognitive symptoms in Parkinson's will typically follow some specific timeline where through every individual, again, it is going to be different, but it's going to be this situation that's going to be distinct. Now, again, there's going to be a lot of questions you may ask me that today the answers may overlap. And not everything, again, is ideal for one person. There's going to be some definite overlap. But cognitive issues with Parkinson's appear later in the stage of disease, sometimes 10, 15 years after the initial motor symptoms. So 10, 15 years maybe after a tremor, a stiffness, a slowness, balance issue. But one of the things we see on a regular basis is there's a lot of delayed diagnosis of Parkinson's. People think they're just tremulous a little bit, and it's got to be from their thyroid, or maybe it's just natural aging. And we see a lot of patients get diagnosed late. But a common feature is, in that decade or later, you see some cognitive slowness. That doesn't mean patients can't function and still work. It doesn't mean they can't do independent care for themselves. But what ends up happening, we stage people with motor symptoms. We call it the Hoehn-Yahr stage. And we can track motor progression, but it doesn't really categorize cognitive decline. So we bundle the cognitive decline into two different stages: mild cognitive impairment, and then Parkinson's dementia. Now, when I say mild cognitive impairment, it can become more moderate cognitive impairment. And a good percentage of our patients have cognitive impairment, and within some time period may develop this Parkinson's dementia. And there's a lot of variability. There's a lot of different statisticians that say 30% of people with Parkinson's will have some form of mild cognitive impairment within 5 years of diagnosis. And then there's others that may say that the diagnosis of cognitive issues get severe, and about 50 to 80% will develop some Parkinson's related dementia after a decade. But again, there's other factors of, like, if someone's had a lot of anesthesia, if someone's had chemotherapy, if there are medicines to help them sleep better, that maybe that causes cognitive impairment. I see a lot of people on benzodiazepines and really strong sleep meds that are associated with dementia. So we want to be really careful that we clear out a lot of those medicines. And many of our patients have a lot of sleep disturbances, and the sleep disturbance that is associated with more cognitive decline is REM behavior disorder, those talking in sleep, acting out dreams, fighting. And if you see a sleep specialist, we can try to manage that earlier in the disease. That's extremely important. So you did ask a very important question. What are the first signs for family members to watch for? I think the early signs in Parkinson's cognitive decline should be that is someone having brain fog? Are they having difficulty forgetting names? Are they having processing speed issues? Is there spatial awareness issues, like they reach for a cup and they're short, or they walk through doorways and they're shuffling their feet? Those are the important things. That's the executive part, the difficulty multitasking. Again, checkbooks, things that used to be easy, they're having a tougher time with. Family members need to come in with the patient and let us know. Not that patients don't want to tell us, they just aren't aware that it's an issue, or they think like, oh, it's just something else, it's not a big deal. But when we're having slowness in thinking, that's when the family members need to let us know, because it's also mistaken as hearing loss, so they misunderstood. The other thing that family members need to look for is when there's attention and focus problems, that fluctuating alertness, patients zoning out, staring off into space, that's important. Or distractibility. If someone is having, like they're losing train of their thought, or they're mid-sentence, it's very common as a cognitive impairment, and we need to know about it.
Wow, this is very eye-opening. I think that we see, as you mentioned all these things, I notice how many times I see this kind of situations and don't really take them as something serious, or as they could be a symptom of disease, like people zoning out or losing train of thought. It happens pretty frequently.
It does. I mean, and in the world we live in, where there's a lot of stress going on, we're not sleeping well. I mean, those things exacerbate even someone who's young, who doesn't have Parkinson's. I know, like, I'm trying to juggle a lot of things, and sometimes I'm distracted, right? And I'm paying attention, but I'm not fully there. I'm not fully present. And, we see that with a lot of people, but it's also that much more frustrating for a patient when they're also having cognitive impairment from a neurological condition.
And before I go into the next question, Dr. T, just to clarify, when people are in these medicines that you mentioned, like benzodiazepine, they can have symptoms that resemble dementia, or they can cause dementia, or they simply aggravate dementia?
So benzodiazepines, these are medicines that we use to help maybe patients sleep when they're talking a lot in sleep, acting out their dreams. We give them medicines called clonazepam or Ativan, and some people know Ativan or Xanax because it's used for anxiety. But these medicines, they slow down areas of the brain. They may slow down the executive function, the area for processing speed. And when you take a medicine at night, it may linger later in the day. When someone wakes up, they're slower to think and process, and we see a lot more aggravation to areas of the brain that are more sensitive, right? So for instance, like if I have a problem sleeping, I may take a Benadryl. Not the smartest thing to do, right? Maybe if I have allergies, I'll take a Benadryl, but then I feel sleepy or groggy, and then I'll fall asleep well. But people depend on these medicines to fall asleep and get better restful sleep. Not the most ideal situation, because you wake up groggy, and I'll tell you, sometimes I'll take something at night like that, and I will wake up and it takes me forever to feel like I'm alert. Like I feel like I have to have more coffee just to stay awake. But patients with Parkinson's, they take the clonazepams, these prescription medicines, they take the Tylenol PM or Advil PM, and it causes a lot of confusion. I had a patient, this was like just right before the winter holidays, they saw me and my PA, and they were having a lot of confusion, and we found out that the patient was taking a lot of Tylenol PM, which is basically a Benadryl with the Tylenol, and they were using it for pain and to help them sleep. And it was 2 weeks in a row they were taking it, and the family didn't know that the patient was taking, and they came in very, very altered and looked demented, like they just couldn't process well. They needed help with taking their medicines. They needed help to remember to eat food, and they just look altered. And the moment they stopped the Tylenol PM, all of a sudden, no more Benadryl slowing their brain. All of a sudden, they were more alert. So there's a lot of medicines that aggravate the brain.
Now let's talk about Parkinson's psychosis. What causes hallucinations or delusions in some patients, and what's happening in the brain?
Now, again, we talked about like some keywords, right? Hallucinations, delusions. This is something that it causes a lot of fear, a lot of trepidation. Psychosis sounds horrible in a way because we associate it maybe with a schizophrenia type of psychosis. It's different. Psychosis means not processing well and having like imagining things that are not there, seeing things that are not there. In Parkinson's, we see visual hallucinations and some auditory hallucinations. We may see shadows, we may see ants, we may see bugs, we may see children around the house or people outside our windows. And then it becomes maybe, if there's a formed thought process, that there is a misbelief, then it's considered a delusion. So as Parkinson's disease progresses and it becomes a dementia, some patients may develop these visual hallucinations or develop these delusions. And it's not just one factor. It is a disease progression, and it can be aggravated again by medicines, but it could also be from our Parkinson's medicines. Maybe our levodopa medication that we use for the motor control that helps the tremors, it's too much in the system. And so the goal is that we give Parkinson's medicine to increase dopamine to help you move, but maybe it spills over into areas that it shouldn't be at, like the limbic system, the area that helps with emotional centers, or in the cortex where it helps us think and process better. So when you get a little bit too much dopamine, more than the body can handle over time, when we're a little bit more sensitive, then we misinterpret these signals as maybe we see something that, like a coat hanger, it looks like a person, or you see a sock on the floor and it looks like a mouse. So these are things that kind of make us have these visual disturbances. So is there potentially a loss of reality? But that could be part of it. There's a natural neurotransmitter called acetylcholine, and that helps us process better. And as Parkinson's progresses, you can also lose acetylcholine. And that's also very important as a critical or crucial chemical in the brain for attention and for memory. So that's one aspect. Maybe we're losing some of, or being blocked by acetylcholine. There's other situations that there's a serotonin imbalance, and it may have nothing to do with dopamine, but the serotonin is low, and that affects us, make us maybe depressed or anxious. And then there's another pathway in the brain for serotonin that's hyperregulated. That pathway of hyperregulated serotonin is something called 5-HT2A. It's a special receptor in the brain. We knew that there is that sensitivity that then creates hallucinations, and we've actually have medicines that target and block that hypersensitivity so that we reduce the visual hallucinations. And that pathway affects and goes to areas of the occipital lobe that the brain misinterprets as a visual hallucination. Now, not that you've done any street drugs, but have you heard of LSD?
Yeah, absolutely.
Right? So back in the day, it was a party drug. In the 70s, it was really big. And LSD, if you have that, it creates visual hallucinations. It causes a psychedelic, theatrical visual hallucination. And in the same pathway of this serotonin 5-HT2A receptor pathway. So when we dampen that signal, that pathway, then we won't get those LSD visual hallucinations. And that can be aggravated or upregulated in patients with Parkinson's. So that's when we've got to target that if we're having that sense of feeling that someone's standing like behind us, or if we're, seeing someone like in shadows coming by us, or a small animal, or patients say there's a cat in the house that darted across the room, or we're seeing some formed hallucinations of people sitting around the dinner table when they're not really there. These are things that, again, are not threatening, but we come across this. And then there's these other issues of delusions that, unlike hallucinations where you see things, they're fixed false beliefs, like someone's being paranoid, someone's out to get them. There's a special syndrome called Othello syndrome, where you believe a spouse is unfaithful, or something called Capgras syndrome, where you believe the loved one is being replaced by an imposter. And you also may see that in Alzheimer's, but it's a lot more present in Parkinson's related dementia. And one other thing I do want to comment is that these thought process, when we're not thinking is clear, it could again be aggravated by other medicines that are slowing down the brain, or like urinary tract infections. You don't have to have a systemic type of symptoms of burning or urinary frequency. Even a mild urinary infection really irritates the brain in someone who already has a Parkinson's cognitive decline or dementia. So we highly recommend getting in to get a urine test, getting with the primary, go to urgent care, because the moment you can treat that, it's so much easier. Patients can recover better. But we do see that these are, so to speak, like kinks in the armor, and people are more likely and vulnerable to maybe develop more psychosis issues or dementia symptoms as time goes on. And so it's like, again, little warnings that the system's under attack.
Dr. T, and I know you've mentioned earlier about how, we live in a very stressful life. And so zoning out could be, just part of, being distracted and whatnot. So how would you assess whether someone is experiencing Parkinson's related cognitive decline versus something else?
Yeah, I mean, I think these are the factors that we have to monitor for, right? Is how is someone sleeping? We always ask, how's someone's quality of sleep? Do they wake up sleepy? Have they woken up numerous times to go to the bathroom? Do they feel well rested? I mean, I want to make sure how many hours that they're getting, and is it really actually quality hours? We may want to have someone get like a sleep study just to make sure that there's no other activating areas in the brain that we're not getting into restorative sleep. And then again, I want to find out when they're getting tired. Is this after meals? Is there certain foods or sugars or certain nutrients that they're lacking? We may want to get a blood test. So there's a lot of different variables when it comes to that. I think medicines play a big role, that maybe certain medicines are taken, they make someone very tired or fatigued. And even our levodopa medicine can make someone tired. I've seen people take medications and they're sitting, they're passively kind of watching TV, and they want to doze off. Well, again, if the brain is stimulated, they're talking with friends, family, they're exercising multiple times per day, or they're keeping their heart rate up, they're going to see less zoning out. But you got to keep your body active. With the Parkinson's progressing, then you're going to see more trends that's easily able to fall asleep, easy to doze off. But, these are the warnings of when you see that it's much more advanced. We want to catch it well before, and we want to make sure that we're not missing those moments where people are having slight word finding issues. They're not having that slight trepidation in getting the words out, or maybe they've had these infections numerous times that then you see cognitive impairment, or maybe it's post anesthesia, there's that slowness. Those are the things that we want to monitor for before it becomes so obvious. Many of my patients, when they travel to different countries or different time zones, they come back and like, man, the jet lag really wiped me out. I'm not doing good for several days or weeks. And then the spouse who doesn't have Parkinson's, they're not having any issue. They bounce back very quickly. So those are like little clues to know what else could be affecting people if they are zoning out.
And I know you've mentioned how when there's dopamine that access different parts of the brain, or that stimulates different parts of the brain, that it might not supposed to, it would aggravate symptoms of dementia.
Yeah, it can. So, these are situations that, like if we think about medicines, right? Like if we were to ask the question, like, how do medications, particularly like dopamine therapies, play a role in triggering or worsening such symptoms? We want to make sure, like, is it a dopamine agonist? Is this a ropinirole? Is this a Nupro patch? Is this pramipexole? These are dopamine agonists. They could aggravate the brain, and at higher doses, that typically we don't prescribe as much of that dosage anymore. We always start with low doses, if any, but they can aggravate hallucinations or make you slow to think. There are other medicines that we use for other conditions. Maybe someone's nauseated. Those medicines can slow down the brain, affect maybe dopamine pathways. Someone who has a lot of anxiety or already has some other psych history, bipolar disease, it can block dopamine in a way, and that could also affect some of our patients who also have Parkinson's. There are medicines we use that are actually for Parkinson's that may help the dyskinesias, and that causes brain fog, like amantadine. So there's a lot of different variable therapies we use on top of levodopa, and then of course levodopa itself could aggravate certain areas of the brain. But I also see that, as we get older, we lose our muscle mass, we lose weight. Maybe the medicines we've been on, we've been chasing certain symptoms. And then as we lose weight and muscle mass, maybe the medicine seems too strong for our system. And so we have to cut back as well. And so those are things that we should always address. Is just because we're on a medicine, we've been on it for a long time, maybe we need to adjust it. Maybe we have to cut back and not think about needing more over time.
Oh, and the reason I was saying that is because I wanted to know what treatment options are available for Parkinson's dementia, considering that you mentioned that levodopa might aggravate if there's too much dopamine. Um,
Yeah,
yeah,
so one of the things we could do is cut back on the medication if we have to. If levodopa itself is the amount that we're taking is a little too much for the system, we want to cut back a little bit. And that may help, but it could also, we have to juggle and do the balancing act. The balancing act, in a way, is like if we cut back on the medicine for dopamine, then maybe someone's slower, they're stiffer, they're not walking as well. So we have to be mindful that maybe if we do make an adjustment and lower dopamine, that may not necessarily be the ideal situation. Remember, I talked about the serotonin pathway, how LSD affects this serotonin hyperregulated or hypersynchrony. Well, there's a medicine called pimavanserin. I use that quite a bit. It comes as the name Nuplazid, and that's a medicine that we work on that serotonin pathway. And it's the only FDA approved therapy that doesn't worsen motor symptoms in a patient with Parkinson's related hallucination and delusion. So that's something that we would utilize. And there are some other antipsychotics that are used. Clozapine, Clozaril is the other name for it. And they help to treat the hallucinations and delusions. But there's a little bit more to that medication because you have to monitor blood levels and make sure the white blood cells aren't being affected. So that one's a little bit tougher for patients to take. Maybe there's a fatigue with that medicine as well. And there's other antipsychotics that are actually used for those hallucinations. And we use those quite regularly if we have to, when it gets quite extreme. And those are the Seroquels of the world, or quetiapine. And I say this so that people are aware that, we use this pretty regularly at very low levels. And we're trying not to use high doses because, again, they may help patients with sleep, but it does reduce that nighttime disturbances and confusion and delusions that can happen. So that's the other thing that we didn't talk about, is that someone wakes up in the morning, they're doing good, they're thinking well, thinking better. And then as the day goes on, there's a sundowning effect. They don't think as well, they don't process well. And that's when they may have this like hallucinations or delusions that could come about. And so we do see that the sundowning effect does affect patients with Alzheimer's. There's much more memory problems, but also Parkinson's patients have this sundowning that they don't coordinate as well. Whether it's their thoughts or their physical, they're slower in their walking. They're not as quick to turn. They may freeze more. They may shuffle more. But then also the word finding is harder in Parkinson's patients. One other therapy, rivastigmine, is an FDA-approved therapy for Parkinson's-related dementia that's keeping cholinesterase pathways around. So anyhow, we utilize therapies for memory and processing, and rivastigmine is used for Parkinson's-related dementia. There's also another medicine called donepezil that we have gotten from the Alzheimer's world, and we use that to help with better processing, communication, maybe even less freezing of gait. And that's kind of an off-label for the freezing of gait, but it's been quite helpful for some of our patients that have developed a Parkinson's freezing of gait. So again, we'll be creative in what we add on, but we also want to take away medicines that could be aggravating to the system.
And on that note, are there any non-drug interventions that you recommend? Things like routines, lighting changes, or caregiving education?
Yeah. So, if you come to our clinic, whether it's my PAs or myself, we try to incorporate not just, pharmaceutical agents, but non-pharmaceutical interventions, right? So one of the things, again, is that we've got to make sure we're sleeping well at night, right? We've got to cut out the sugars at night. We can't have sweets and dessert and ice cream at night because it does aggravate the brain. The brain doesn't get rested. It's hyper, and these pathways stay awake, and then it allows us to ruminate more. Potentially, we have sugars. The body needs to clear the sugars. We have to wake up and then pee more. And that's another thing that disturbs sleep. Alcohol, very toxic for the brain. Yes, it affects balance centers, but it doesn't help sleep cycles. And there's a lot of literature out there. There's documentaries about alcohol, how toxic it is for sleep cycles. And one of the things I would say is that if you can cut out alcohol and sugars at night, it's extremely important. Really focus on diet, be very clean living as much as possible. But lighting, right? Lighting is very stimulating. We're working on a lot of interventions, whether it's red light therapy, blue light therapy. Does that help the brain during the daytime, evening, or nighttime before one goes to bed? But we have to stay off of the phones, the TVs, the iPads before we go to sleep. That's very aggravating as well. So we want to integrate that non-drug interventions. Music therapy, light music can be helpful, but if you listen to something that's too stimulating, maybe it keeps someone up. And then the other aspects, again, I would probably say is not having too much water at night, so that maybe, again, you have water you're drinking throughout the day, but not too much to irritate the system to go wake up to go to the bathroom. Now, many of our patients, we focus on exercise. And how does exercise affect the thinking and the processing? Big time. It's important to keep the body stimulated, the heart beat faster. Then maybe, again, the muscles are well toned and the brain wants to be optimized. It doesn't want to feel sleepy. So the more cardiovascular exercise we're doing during the day is going to be key. Maybe you don't want to do too much at night, but you keep some early morning or late afternoon exercise going. Mix it up. Don't overdo it that you're so fatigued and tired that you actually want to doze off and your body needs to rest during the day. We also order occupational therapy. But one of the things I would probably say is medications need to be also, monitored. If the family member is noticing that the patient's more confused after medicines or getting cognitive impairment, maybe the medicines need to be given by the family member to make sure that we're not accidentally taking the wrong medicines. I've seen cognitive impairment or dementia come about because we're just taking the medicines incorrectly or too close together. And keep the schedule simple. Don't have too many busy activities in one day. One day you do a doctor's appointment, next day you're doing certain activities, maybe spread out a physical therapy appointment here, a speech therapy appointment on another day, but don't feel so overwhelmed. If we simplify the day, then it's not too aggravating for the patient. And I see a lot that during daylight savings, people are more alert, there's more sunlight, so people out and about and there's less confusion. But in the fall, when there's more darkness, we see a lot more earlier confusion. So I really recommend getting to bed early. When it starts getting darker earlier, you get to bed earlier. And that's a huge part of it. And a lot of our patients really struggle when the clock is shifted earlier.
And what advice would you give to caregivers who feel overwhelmed, exhausted, or unsure of how to respond when a loved one experiences hallucinations or confusion?
Yeah, that's a wonderful question. I'm glad that you're asking that. So the advice that we give to caregivers who feel overwhelmed and exhausted, number one, there's no correct answer here. There's so many different ways of attacking it, but it's not something that that is going to be tackled in one advice. So caregivers facing those, like with a loved one being affected, you really want to understand that you are addressing someone's cognitive and emotional needs. There's a lot of overload, and that's a warning sign. It's not a sign, it's not a sense of failure. So what we have to do is caregivers do feel overwhelmed. We know it's a high burden on them. Okay. But the patient and the caregiver need to come into the clinic, right? We need to understand what are the predictable factors. We need to talk about like what the uncertainty is during the daytime, what the sleep disruption is. Is there any, if the caregiver's emotionally burnt out, then, they're not sleeping well. And then it doesn't help the patient either. And the patient themselves are worried about the caregiver. I mean, it becomes this very vicious cycle, right? So number one is the caregivers themselves need to seek a counselor. They need to take care of themselves. They need to get their regular blood levels checked. They need to still keep with their friend circles. They got to have respite care if they need be for the patient. Like everyone needs to be in good health. And there's a lot of fatigue that happens to the caregiver. So we tell the caregivers, you've got to have extra support, have other family members involved as well. Don't try to tackle everything. We have really wonderful patients, and we have really wonderful, loving spouses that come in. And I'll tell you that I see the agony in their face. They're tearing up and they're really frustrated, and there's a lot of fear about what's going to happen in the future. We got to plan ahead. We got to know that when there's cognitive impairment, before it becomes dementia, we got to stay ahead of it. What do they need to do? Make sure the house is safe. Make sure there's less risk of falls. Open up the area so someone with Parkinson's dementia isn't falling and tripping. Make sure we get into physical therapy early for the patient. Make sure they're using their right assisted devices. Make sure there's a hospital bed or a bed that has a side rail so a patient can get in and out of the bed easier and go to the bathroom easier and not feel like they're dependent on the caregiver. Maybe hire a nighttime nurse, whatever it may be. Get support. Don't try to take on everything by themselves. And we need to minimize that burnout that the caregivers go through. And if we were to give advice about what do you do in a situation where someone is maybe having a hallucination, do you argue with them and say, no, that's not there, that's not real, you're making it up? No. You know what? Like, it's something that you don't want to confront or correct the hallucination. You kind of want to validate, look, maybe you're seeing something. I don't see that. Maybe it's not happening. Is not the right answer, right? Maybe he says, maybe that sounds like that's what that was. Or, maybe I think you're seeing something, but I don't see it right now. Maybe you're misinterpreting something, but you don't want to really agonize the situation. And so maybe you want to redirect, right? And do it so gently. Sometimes it's hard being a caregiver, and it's easy to be like, that's not real. Like, why do you keep saying that? And we want to, again, demystify that. Let's try to keep on an even way of speaking to our loved one, so it's not aggravating for them. You know what I mean? So again, there's so many different ways about it, but redirecting is always a calming, smoother way of that transition.
And Dr. Thakkar, before we close, what do you wish more doctors understood about how to support families when these symptoms emerge?
As far as other doctors, I mean, whether it's neurologists, whether it's psychiatrists, whether it's a primary care, I think we all have our responsibility. And, we can help support our patients with Parkinson's, our dementia patients, our Alzheimer's patients, get home health involved. There's home health agencies with nursing, with caregiver respite care, with hospice care, with palliative care. There's different agencies that help with DME or durable medical equipment so that patients can get the hospital beds, that can get the scooters, the walkers. Those things are very important. Maybe earlier recognition for physical therapy, maybe working with occupational therapists. Those are really important. So the earlier referrals are important. Maybe even as a neurologist, we want to get the neuropsychologist involved. We want to do cognitive testing. And that's a good valid way of validating the testing. Is this a cognitive impairment or is this anxiety? So we really want to get the neuropsychologist involved. Maybe we want to have fast tracks to a movement specialist like myself who focuses on Parkinson's. And so again, it's really, everyone needs to be connected when it comes to whether it's the primary care doctor, like I said, or it's a specialist, an endocrinologist. We want to make sure everything's stable. One of the other things when it comes to cognitive impairment, and we have the caregivers burnout, right? Getting a social worker is going to be important. So we've got to get the referrals to the social workers as soon as possible. I would also just again want to say that the neuropsychologists are so key. And in the beginning of any cognitive impairment where patients are, slower in their word finding, if they're feeling like just things aren't right, they're having difficulty at work, difficulty with that checkbook balances or driving, maybe we get a neuropsych testing and then we get a baseline testing and maybe want to repeat that testing 6 months or 12 months down the road. So then we are knowing how things are declining, if that. But also, every time you come to a doctor's appointment, have an updated medical list. Make sure that medication list that is there and is always checked and updated, not only by the patient, by the caregiver, so that when we're giving information to the doctors, we're making sure we're not missing anything. Not all doctors are on the same electronic health record system. So that's really, really important.
Dr. Thakkar, thank you for breaking down this complex and deeply emotional side of Parkinson's care. If this episode helped you, please share it with someone who needs it. You can listen to more episodes and learn more about Dr. Thakkar's work at thecaringneurologist.com. Until next time, thank you for listening and take care of yourself and those around you.